Welcome. It's great to see so many of you joining us early. We're going to start promptly at 3 o'clock Eastern Time. While we wait and while others join, please feel free to introduce yourselves in the chat box. Please share your pronouns, where you're from, what you do, and keep those comments rolling. Again, we'll start right at 3 o'clock Eastern Time. Thank you. Welcome, everyone. Please keep introducing yourself in the chat box. We'd love to know who you are, where you're from, and please share your pronouns as well. We're going to start promptly at 3 o'clock Eastern Time, and it's great to see such an outstanding participation from across the country. Again, please continue to introduce yourselves in the chat box. One trick, when you're introducing yourselves, please select all panelists and all attendees. That way everybody can see who you are and where you're from. We're going to start promptly at 3 o'clock Eastern, so we have 3 more minutes. Please continue those introductions. Welcome again. We have 1 minute before we start. Please continue to introduce yourselves in the chat box. Please be sure to select all panelists and all attendees so that everybody can see you. Otherwise, it's just the panelists who can see your introductions. We'd love to know who you are, where you're from, what your role is, and your pronouns, if you'd like to share them as well. We're going to start in 1 minute. Welcome, everyone. I am Denise Solzbach, the Director of the National Center at the Institute for Innovation and Implementation at the University of Maryland School of Social Work, and I'm also the Deputy Director of the TA Network. Thank you so much for joining today's conversation in our series, Managing Now for a Better Tomorrow, Addressing Equity During COVID-19. We first began these conversations back in March when COVID was new to us, and we focused on how to manage through the immediate challenges in our work. This fall, we are refocusing the series on the Better Tomorrow part of the title with forward-looking solutions to help us all create a brighter tomorrow for the youth and families that we serve. I do want to acknowledge this past week has been difficult for all of us, no matter how we voted. I know that today's opportunity for peer-to-peer learning will help all of us in creating a better tomorrow for all of our children and families. Please use the chat box. You're really good at it. I can see all of those chats coming in now. Continue to share your thoughts, your resources, and questions with the presenters as well as one another. In follow-up to today's discussion, we will send everyone who registered a link to the recording, as well as resources and insights shared in the chat box. This webinar is being recorded, and it's also being live streamed to our YouTube channel. Due to the large number of people who have registered, participant audio will be muted for today's discussion. If you are joining us through Zoom, you are welcome to submit questions and comments and resources in the chat box. To make sure that both the presenters and the other participants can see your comments and questions, please go to the To field in the chat box, click on the drop-down menu, and make sure to select all panelists and attendees. If you are joining us via YouTube live stream, please post your comments, questions, and resources in the comments section. Maryland law requires us to tell you that this discussion will be recorded. And while participant audio will remain muted for today's conversation due to the large number of attendees, your questions and resources may be read or recognized verbally by the panelist. Your participation via the chat does imply your consent, but again, please, we truly appreciate your contributions, so keep them coming. They truly do guide our dialogue. At the end of our discussion today, an evaluation will pop up for you to complete. We ask that you take a moment to complete this evaluation, as your feedback will help us to make this series better and more responsive to your needs. And we will be tweeting through today's discussion. If you would like to join us, please use the hashtags BetterTomorrow and TA Network Talks, and please tag us at Institute UMSSW. Next slide, please, Sarah. If you'd like to sign up for conversations, future conversations, as well as view recordings of prior conversations and access our resources, please check out our website. Next slide, please, Sarah. And as you know, today's conversation is on mobile response and stabilization, supporting children, youth, and families during COVID-19. Next slide, please. Our moderator today is Liz Manley, a clinical instructor for behavioral health and health policy at the Institute. Many of you know Liz through her leadership with the TA Network. She is a technical assistance lead for several states and sites and has led the TA Network's mobile response and stabilization learning community for several years now. Liz, thank you again for joining us and leading today's discussion. Joining Liz as panelists are Hazelyn Pilgrim. She's the Executive Director of the Family Support Organization of Essex County, New Jersey. Welcome, Hazelyn. As well as Craig Walters. Craig is the Stabilization and Mobile Response Director with the Utah Department of Human Services. Thanks for joining us, Craig. Also joining us today is Christopher Balanci. He is the Vice President of Policy and Practice and the Chief Medical Officer at Judge Baker Children's Center at Harvard. He is a board-certified child and adolescent as well as adult psychiatrist, and he has served as the TA Network's medical director since our inception. Also joining us today is Ann Polakowski. Ann is the Clinical Program Manager for Community Services in Nevada Department of Children and Family Services. Thanks for joining us, Ann. I want to welcome all of you and thank us again for joining us. And Liz, it's all yours.
Thank you, Denise. We're so happy to be here today to talk about a really important topic, right? Mobile response and stabilization is one of the, I've always said, one of the smartest services New Jersey ever invested in. It's an upstream intervention that allows families to get help when they begin to recognize that things are beginning to change with their children. And it really helps families be able to sort out what is really serious that requires higher intensities of service, and what can we do early to re-engage children in communities, get them back into school, and help support them. In the age of COVID, mobile response and stabilization has become quite a challenge to provide. And today's conversation is, where do we go from here? We've learned a lot of lessons on the ground around mobile response and stabilization. We've learned what works. We're still learning what other tools we might be able to use. In today's conversation, we're hoping to learn more. I'm really excited about today's panel because we get to talk with some of my favorite folks who are doing some really interesting and creative work around the country. So today's conversation around mobile, I remind you, just put it into perspective, mobile response and stabilization is an upstream intervention that allows us to go in at the request of a parent. It's always driven by the request of a parent or a caregiver. And it is not necessarily a crisis service in the way that professionals think about crisis. We don't require children to have to demonstrate
Liz, you've frozen, I'm afraid. So maybe I will jump in.
Go right
Yes.
ahead, Christopher.
Please, thank you, Christopher.
I'm Christopher Balanci, and Liz was going to throw it to me next to talk a little bit about the impact of COVID on children and families. And there's really two impacts as I see them related to mobile response and stabilization services. One is, how do you keep your staff safe when you're sending them out on response calls, assuming you are still doing that? And that is a two-way street, right? So you want to make sure that your staff aren't inadvertently infecting the families you're responding to and the children you're working with. And you want to make sure that your staff aren't becoming infected in their contact. So PPE, distancing, how is that doable and how are you doing that? And particularly in light of the most recent data we're getting. So as of October 29th of 2020, since the beginning of the pandemic, there have been 853,000 child COVID-19 cases. And that represents 11%. And I just want to note that at that time, so this is just October 29th, there was a total of just over 7.5 million cases in the US. We know now that just in the, what is that, even 2 weeks time span, we're now over 10 million. So we're seeing a real exponential growth in the numbers of cases in the country, and children are increasing in their representation in those numbers. So just in the last 2 weeks, there were, well, in October, there were nearly 200,000 new child COVID cases reported from October 1st through October 29th. And that again is going up significantly. Children made up between 5 and almost 17% of total state tests. And hospitalizations are also starting to go up with children as well, although they still remain relatively small. We're talking children were 1 to 3.5% of total reported hospitalizations. And mortality rates for children, fortunately, are also quite low. 16 states have reported 0 child deaths. And for the whole country, it's between 0 and 0.2%. So, you know, children, as we know, don't get as ill from COVID, but they can transmit COVID, and they can transmit that to adults, and they can get it from adults. And then, of course, we have asymptomatic cases. So one is, how are you managing the infection aspects of the disorder, and how are you ensuring and trying to keep your staff safe from causing others to become infected or becoming infected themselves? The second big piece of this is the behavioral health sequelae from this pandemic. And early on, I was seeing exponential rates of anxiety, almost trauma reactions, grief reactions, certainly to those that had lost loved ones. We've had over 230,000 deaths in the country from COVID. The spread of those deaths are significant. So for each death, that death is touching many people's lives, many children's lives, and particularly with significant disparities around people of color, Black and brown children, Native Americans. So we're seeing disparate effects again in the impact of this pandemic. So initially kind of anxiety and grief reactions. As we got into the fall, I'm starting to see much more despair and depression, and with some significant concerns about increased substance use disorders and suicide. And there was a study done by the CDC in July of this year asking adults, just over 5,000 adults were surveyed, how many of them had in the last 30 days seriously considered suicide. And for the whole study, it was just over 10% of adults were reporting that they had seriously considered suicide. But if you look at the young adult population, 18 to 24, that was 25.5%. Fully a quarter was saying that in the last 30 days, they had seriously considered suicide. So I think we're seeing potentially a second pandemic of behavioral health sequelae from this pandemic and the responses to the pandemic that are putting stress so significantly on all families. So I think what you're probably going to be seeing, if you haven't already been seeing it in the mobile response and stabilization services, is a big increase in demand for your services related to disorders of despair. So whether they're overdoses from substance use conditions, whether they're intentional suicide attempts, and anxiety and depression are primarily what I'm seeing. So I don't see that Liz was able to rejoin us. So I'm going to ask our panelists to weigh in on, what are you seeing in your jurisdictions and how are you managing the response to those crises amongst your staff and in the field. So I'm not sure what Liz's order was, so I'm just going to go and see. Craig, do you want to respond first?
Sure, happy to. Thanks, Christopher. So in Utah is an interesting environment in and of itself, and COVID has absolutely exacerbated everything you just said. So, Utah had a high suicide, mental health, behavioral health was a growing challenge for Utah prior to COVID. And COVID, all of those pieces that you said are absolutely happening here. COVID did teach us some lessons, so I want to focus on those positive lessons first. And of those positive lessons, it was about being creative and leaning on that family-driven piece of this program. It is fundamental to stabilization and mobile response that the family drives this. And while we were trying to flex with COVID, we found it really effective. Instead of saying, hey, we don't feel comfortable engaging in your home, instead we offer the options to the family and let them drive that. We did work with all of our administrators around the state to create a triage scale for health and safety first. And then also offer those other tools like telehealth with those families. Now we're about to expand, we're right in the middle of expanding SMR, which this works really well for us as a proof of concept period for the telehealth approach. As we expand into a very eastern rural area of Utah, it's the largest geographic area and the most frontier and rural area of Utah. So this is a great time for us to look at the data outcomes from us testing this telehealth, both for the protection of our frontline staff, but also for the accessibility of those children and families that maybe feel a stigma about someone coming into their home at first and want to create some trust and some connection before going to that sort of level. Or maybe they just don't have, they're not in an area where we can access them in a timely way. And this could be a great stopgap piece before we engage with them in that intensive stabilization in-home portion of our services. So that was something very positive for us during this challenge of COVID. is allowing telehealth to be an option. And our administrators are creative. They have iPad devices that are in lock boxes that they can sanitize, drop off, provide telehealth, and then schedule a pickup for, or do telehealth via whatever method that family has, a cell phone, an iPad. And then if that's not available, or if the challenge at hand is just too much for that family to handle, we'll say, can we meet outside? Can you make sure that, we'll drop off masks and we're going to stay 6 feet apart? Sometimes the family will opt for that approach, or meet somewhere in the community instead of in the home. So it's not perfect. It's not ideal. We always want to be in person with those families, especially when they're having those challenges. But COVID has allowed us the freedom to try out some new approaches and really analyze, is this working, and has this worked?
That's such a critical point, Craig, that, in crisis, there is opportunity, if you will. And so what are the aspects of the mobile response and stabilization services, the adaptations you've made, and this has been true for telehealth as well, that we want to see continue after the pandemic? So there were two questions, quickly throw back to you, Craig. SMR, you use that abbreviation. Somebody was asking what that means.
Stabilization and mobile response. We've just reversed it a little bit so it didn't look like misses. When in government, we love acronyms, so. Gotcha.
And then there was also a question, what % are still in person? So are you triaging, are you making determinations on which calls get a in-person response, and how do you make those determinations? And I'm going to ask the other two panelists as well the same question.
It's an awesome and yet tricky question. So Utah was fairly low transmission rates until very recently, and they have exploded like most of the country. And in that explosion, we stopped, and our administrators are very scared because we have a lot of our teams had to go into quarantine, and that becomes a major barrier. And so in order to slow that down and stop that, we are pushing more and more for the telehealth and trying to make it, yet driven by the family, say this is an option, it is, let them know it is driven by a clinician, we can engage in, more in person later, but right now, because it's so unknown and so unsafe, would you be comfortable with this type of intervention? I would say right now it's probably 80-20. Prior to the very recent increase, it was probably 50-50, but our administrators are definitely asking for more permission to slow that down out of the fear of our spikes that are happening.
Hazelin, can you chime in about how things are going in your part of the country? You're muted. There you go.
Here in New Jersey, early on, we saw a little bit of an adjustment period with folks going out into the homes. Of course, as you know, this area was particularly hard hit. We're very densely populated. And by July, folks were beginning to go back out into the field, of course, using all of the necessary precautions. As family support organizations, we were very proactive in providing PPE and providing education to families on how to use the various digital platforms that were available to them so that their voices could continue to be heard. As recently as this week, we've learned that there are some ongoing concerns with the rise in numbers about being out in the field. And so family voice has always been really important here, and families are given the option of face-to-face outdoors. We've been very creative. We've had people agree to meet in the backyards or on the front porch, of course, armed with masks and hand sanitizers and so on, or using telehealth. And telehealth has been more widely accepted than some of us may have thought in light of the historical issues of access and technology.
So I'm happy to be back. I'm so sorry about that. Nothing like life in in the age of technology. So just to pick up, Hazelyn, I just have another question for you in terms of some of the lessons learned around the quick shift in New Jersey to telehealth, and how the telehealth technology has been both helpful and maybe some of the challenges.
So I think what we learned is that we have an incredible will to get things done, and that we were able to adapt rather quickly in a very dynamic situation. You know, I was speaking with a colleague, and this is so unlike what we went through with Sandy, which was also a monumental environmental event in New Jersey. But I think on the whole, we were able to adapt and to deploy technology rather quickly. And I think it speaks to the strengths of the partnerships between the various entities within the system of care and also outside. So we've worked closely with our system partners, we've worked with education, we've worked with public service and cable companies to advocate for families to be able to access the tools that they need. Now, that being said, I don't want to create the impression that it was all perfect and flawless, because we do know that there are still issues of disparity when it comes to access, not only to the technology, but to the bandwidth, to the strength of your internet connection, and even access to some of the devices themselves. Recently, we have continued to monitor that. And I know that we as an agency and others have provided support to families so that they know how to access those resources and where to go for help. We've even done some work around training families. On our website, you know, there were webinars posted on how to download and how to participate and how to protect your privacy. So those are some of the challenges, the opportunities that we've seen and things that we've done. Challenge continues to be addressing the digital divide, which I believe the Department of Education recently did a survey that showed that families, even after all that we did in the spring, are still experiencing a digital divide. So that there's some work to be done there. I believe of the students enrolled in K through 12 in New Jersey, about 230,000 of them are still not having reliable access to technology for learning. So we know that that then carries over into our work with families, and the reliability of their networks and connections is a continuing concern.
It seems that you have you've hit on something that even Marianne White from South Jersey, who runs mobile response and stabilization, is reporting in the chat box that that even during the height of COVID, 75% of the work that they did continued to be face-to-face because of some of the challenges around technology. That's not a big surprise, even in a small state like New Jersey that has access to pretty broadband technology, but there are pockets that continue to be challenging, and Marianne is certainly in one of those. Not only that, some of the challenges around families really being interested in engaging. So I know that Anne does a ton of work around the telehealth and in the more rural parts of Nevada. I was wondering if, Anne, you wanted to talk a little bit about that.
Absolutely. So when COVID hit, our rural and frontier areas were very well equipped and very well prepared for this, because all of the service delivery happening in the rural and frontier was happening by telehealth on a video platform. So the urban areas of Las Vegas and Reno were the ones who really had to adapt and pivot and be flexible and creative, and worked with our rural and frontier partners and our mobile response teams out there to say, help us, we don't know what to do. And they did. So that was amazing. Our rurals do use a video platform, and they have built amazing relationships within their communities in the rural and frontier areas to help families who may not have access or devices. So they've built relationships with community centers and pediatricians' offices and police departments, fire departments, and schools for families to be able to access equipment needed or to get bandwidth or that kind of thing to be able to access services. So our rules were just right there on the cutting edge when all of COVID happened. That was pretty amazing.
So, Anne, do you have some ideas about some of the training that you do for the folks in the rural communities around the use of telehealth? Like, how do they engage families, and how does that work? Are there challenges around engagement with families?
There are always challenges, right, with equipment, with technology, with making sure that families have the resources that they need. And so, like I was saying, they have built those relationships in their communities to do that and continue to build those relationships. And they are really talented, our teams in the rurals, of walking families through how to access their video platform and have it really down to a science at this point. It's very simple to get families to access their video platform and to engage that way. And our rural and frontiers are actually able to get to families quicker than the in-person at times because of that.
Because you've been at this for a long, long time. And so it seems like the families have been benefiting from it. Was there any shift at all or any challenges at all around COVID at all for the rurals, or were they just really, have you seen an uptick in the use of mobile since COVID?
We have seen an uptick in the urban areas, not so much in the rural areas. So that has remained steady in the rural areas in terms of access. And then in the urban areas, we have seen a huge uptick with the telehealth and really are providing a hybrid. Again, as Craig has said as well, it's really driven by the family as to if it's an in-person response, an in-person stabilization. Do they want to come to us? Would they like us to come to them? Do they want to use one of our video platforms? So that really is much like crisis is driven and the definition of when they need help is driven by the families. We've now added the service delivery method and modality is driven by the family.
That's amazing. I'm wondering if we could talk a little bit about some of the special populations, right? So Craig, you and I have been talking about some of your work around the LGBTQ population, and you had some really interesting things to say. I was wondering if you wanted to talk about that.
Yeah, thanks, Liz. That has been a really big lesson for us in Utah during COVID. One of the challenges we had with telehealth was engaging children, which we thought was not going to be the issue. And then one of the other issues we've seen was this growth in connection with the LGBTQ plus community. And it could be timely. There's a cultural piece of that in Utah. The culture in Utah, creates a divide there, which has a strong connection to our mental health issues and some of the suicidal ideation that happens in the state. That has been a really interesting piece for us to target this year. So this is the third year of our program as we expand. We've just expanded into the most urban area of the city, which has allowed us to do a couple of things, kind of uncover this piece. And the challenge when we have families who we are their trusted source, they tell us to deploy, we deploy. And when we get there and start to break the pieces of the challenges apart, and we discover this child is identifying some sort of LGBTQ issue. And the family says, in this home, we don't believe that. And we found ourselves asking our administrators and our partners, well, what do? We can't just walk away. How do we equip that family? And we can go the traditional route of, yes, we provide the family with resources and the science behind everything, but we have to keep that trust with the family. And one of the pieces that we have in Utah is a free text app called Safe UT. And that app is for children and youth to text and speak with a mental health professional at any time for any challenge. So we wipe the LGBTQ issue off the board. If the family says that's not a conversation or a belief in this home, we'll educate, try to connect, provide resources, but then we give that child and youth access to that app. They can access it on their phone or on the web. And then that child and youth has a lifeline. We leave and equip that family with resources, peer supports around those LGBTQ issues. And then we can dive into some of the other issues around the family, like maybe there's not communication happening or that family doesn't have the skill set, and focus on those mechanics versus this very tumultuous LGBTQ issue. It has been interesting to see that arising, whether that is just our expansion is happening and the climate of what's happening socially, or if perhaps people being at home, that is becoming an exacerbated issue. There could be a lot of pieces to it, but that was a really interesting thing to me. It's absolutely something worth addressing. Like you were talking, Liz, at the very start of this, if stabilization mobile response or mobile crisis outreach or however we phrase these tools,
right,
is going to be effective. It's about engaging very early prior to that child or youth having suicidal ideation. And if we can engage that family, challenge some beliefs, show them some of the safe ways to access information, including that youth who we all know that 0 to 10 age group is very hard to break into. There's not a lot of data around it, excuse me, and there's not a lot of programs, at least in Utah, for that age group. So to me, that is, some of the earliest ways we can intervene and bend that curve proactively for those children and families and avoid a whole slew of other challenges down the road if we can equip them with knowledge and resources and community supports.
That's amazing. So I think that the conversation that's happening around just the use of SMR in Utah has been really interesting. And I get used to calling it SMR rather than mobile response, which I've been clearly trained to call it for many, many years. Let me just talk about crisis just real quick. Mobile response and stabilization generally doesn't have the word crisis, or teams are moving or thinking about how to take it out. And the purpose of that really is not about families. It's really about making sure professionals know that it's okay to accept and do the work, right? And really not about, it's about retraining the workforce to say, when a parent picks up the phone, a caregiver picks up the phone and asks for help, then we provide it. We don't debate it, right? So that's the core value within mobile response and stabilization. Another special population we want to talk about today, and Hazelyn, I know you've done a ton of work of this in New Jersey around working with children and youth with intellectual and developmental disabilities, and how powerful an intervention like mobile response can be. Wondered if you wanted to share some of your experiences.
During this pandemic is the opportunity for parents to be more involved in what is actually happening with their children who are receiving these services. The virtual platform has allowed parents to actually participate in some of the sessions and better understand the work that's being done one-to-one in the homes with their caregivers. So I've heard that from a number of my colleagues who are raising children with intellectual and developmental disabilities. One of the concerns, of course, has been the safety factor and the willingness of families to have providers come into their homes during this time, even to provide much needed respite services. So they've been more welcoming and accepting of the virtual services and participating in that way. I think that for us, and I say us because I grew up in the IDD, Intellectual and Developmental Disabilities Advocacy Movement as a parent. For us, we find that this has opened a whole new world of opportunity that was born out of crisis that we could not have imagined previously. One of the things that has been really great here in New Jersey is that we've partnered with the New Jersey Council on Developmental Disabilities to help put tools in the hands of families and young adults so that they have the technology to participate in their virtual day programs, virtual learning, social connections, cooking groups, exercise groups. And so it's been pretty remarkable in terms of how creative people have become. Some of the older caregivers, I think, have had challenges with adapting to the technology. So I think that there's a place there for some improvement in terms of training, parental training, and collaborating with the schools and using the IEP portion of the of the related services portion of the IEP to facilitate parental training so that they can use those tools with their youngsters.
That's pretty amazing. So I think that, one of the things we wanted to talk about today, we hit on some of these special populations around the rural communities and rural engagement, around engaging young people with intellectual and developmental disabilities. And, so the reason we wanted to touch on these special populations is because we believe that the work of mobile response and stabilization is an equalizer in many ways. It brings services and supports to families at the time that they ask for it, without having to jump through a ton of hoops. And so it really can be a service that addresses stigma. I'm wondering, before I even get to that, let me just also say it can be a really powerful intervention for children in the child welfare system. So I just want to tell one quick story from my time in New Jersey, and that is that mobile response and stabilization as a matter of policy is provided for every child who is removed from their home and placed in a foster home because of concerns of abuse and neglect. And mobile response and stabilization has helped us stabilize that first place that young people go in by addressing the actual trauma that the child has experienced for no other reason than that removal itself, the removal from their home into a stranger's home from their perspective. And how do we help young people cope with that? It's been a really powerful intervention in New Jersey. Quick story, in the pilot, 46 out of 46 young people who were removed from their homes because of concerns of abuse and neglect stayed in the first bed that they went in with 0 behavioral moves, even though prior to that they averaged at least 2 to 3 and 6 by the time they touched into the children's system of care. So just one of the populations we wanted to put on the table today to talk about. The other thing we wanted to talk about today is that crossroads between COVID, this real challenge of COVID, and where we're at with that, and the racial unjust, right? The justice issues that are happening now. And for all the panelists, I'm wondering if you wanted to take a minute and talk about that impact and how that's impacted your work. And for folks who are listening, if you wanted to ask any questions or share your experiences around how a service like mobile response and stabilization could be helpful in really leveling the playing field, in particular helping police officers engage with children. Why don't we start with you, Craig, around your experience with some of this work?
Probably nodding vigorously, I didn't realize it, but this is a hot button for us here in Utah. I don't know if you guys have seen the headlines, but we've had 2 recent incidents with children and youth. So it's timely, it's unfortunate it's happening during COVID, but it's given us a time to really sit back as a state and evaluate how are we using this early point of contact, and how are we using other resources in our communities. And I first and foremost don't want to disparage our police. Our police are doing amazing work. And Liz, I learned this from you early on, but a police officer, no matter how amazing they are at their job, look at the tools in their tool belt. And the tools that police officer or law enforcement have around them are never tools that will have an outcome that we will be happy with for children and youth. So we never want those instances to mix. They should never mix. And if something happens, we can't fault that cop who's doing the best they can with the tools at their side. So I want to get that off the table. And no means are we disparaging our law enforcement. We're so grateful and appreciative of the work they do. But instead, what we have used this time, we've rolled out a new SMR team in Utah, and actually our most urban area in Salt Lake City. One of the largest healthcare providers is stepping up with a donation of their own money to be the SMR administrator in Salt Lake. Now that is awesome, but it's a little challenging because we already have these mobile crisis teams, which are geared towards adult and acute and emergent need. They have these special teams and cops that are geared towards, maybe some mental health or crisis, but it's a very small team that does some training, and we're pushing against that. And to do that effectively, what we've learned that's worked really well is let's just sit down with those police forces. Let them understand how stabilization and mobile response, these children and youth focused teams, are there to help them They're there to help us, so they have our back should things start to get more aggressive. They need support. We're there to go in there so they don't have to, so they can focus on building safety in our communities and not dealing with behavioral and mental health and developmental challenges. And it's been a huge learning curve for us. They allowed this new team to come right along with them for several weeks while they were onboarding, and to see what are some of the calls that you're seeing in Salt Lake, because it's going to be very different than some of our other providers in other parts of the state. So I think that just coming to the table where we're not pointing fingers, we're not saying you're doing a bad job, we're doing a better job. This is going to take all of us together, not just the traditional systems, and we need each other to understand our roles and how we can help, and we need to be able to rely on each other. And for Salt Lake and for Utah, I'm really optimistic about. Yes, we had some bumpy roads. We did have those recent incidents, but I feel like people are now stepping back and saying we're listening to that, and with that, we're trying to forge new partnerships and help our leadership and legislative bodies understand why that's so important.
That's so wonderful. So there was a comment in the box from Tara Rice, who said we need a universal collaboration model for working with police and our children and families. And I just want to address that real quick and by saying that, when we use an upstream intervention like mobile response and stabilization, the goal is to train police officers on how to call, how they call. They don't go. They don't go to homes. They don't respond to calls. They call mobile response, and the experts who work with children go and work with children. And that's a really important value within the world of mobile response and stabilization, that we don't arrive at people's homes with guns. We arrive with crayons and tools and communication tools for those young people. Okay, thank you, Craig. Anne, I'm wondering if you could take this question in terms of, have you seen the impact of mobile response and stabilization with some of the racial justice issues that we're currently concerned about?
So we have, and if I can just go back quickly to talk about the law and some things happening with that as well. There was some legislation passed recently in Nevada where mobile response would be involved prior to an involuntary hold for youth. And so we are really working on defining what that looks like and how to get mobile and that education and that connection. And another thing that we have done recently is rewrite some protocols within the school districts and connect mobile response. And this is brand new as of this week, connect mobile response to our Safe Voice app, which is the app that schools are using for tips for suicide or anything really. And so we're going to be connected with that platform. And one of the things that we're going to be able to do is remind people when these tips come through that we can be an intervention, that we can respond, that we're available to do that, as opposed to it having to be a law enforcement call. Or if it is a law enforcement and they're dispatched first, instead of having to take to an emergency department, we can come in and provide that assessment support and stabilization. So this is something that we have been talking about doing for quite some time in Nevada, and is really starting to come together as of right now, actually, as we speak. So it's exciting stuff. So stay tuned for all that exciting,
right?
Yeah.
So go ahead.
No, go ahead.
Finish up. It's all you.
I was going to shift to your original question.
Right.
So in terms of the racial justice and those issues that are happening, one of the things that we have seen is that it really has allowed us an opportunity that the conversations can happen, because it's right there, right? It's on TV, it's happening in our communities. We've had protests that have been violent and lethal here in Las Vegas. And it really has allowed that opportunity then to just talk about it. And that has really been amazing and critical for us to do a proper assessment and a proper safety planning and really support the families and support our youth in a way that we weren't able to do quite the same before. It also has been very important for us to look at our staff and hear our staff and recognize that for the people who are out there responding and holding our families, that they're experiencing the same trauma and the same similar experiences as our families. And to honor that and to hear that from our staff and from our staff of color and from our Black clinicians who are saying this is impactful to us, and to remember the impact on them while they're holding our community. So
Yeah.
it's been a really interesting and beautiful time of opportunity and learning and growth, and really changing our practice, I think.
That's amazing. And I think important, really important. I'm just going to tag back to the police question real quick one more time, because I don't think I was clear about it. I think I talked about the response. You know, I think it's incredibly important that mobile response and stabilization be incredibly good partners with their law enforcement, right? Providing ongoing training, dialogue, conversations, opportunities to connect and organize around concerns and challenges that police officers are facing. And I would find any opportunity that you can to be able to engage with law enforcement as partners within the context of this work. But my point about going to the door with crayons is that whenever possible, and that is truly most of the time, if we can use mobile response as that upstream intervention, there's a rarity of the times that police officers need to arrive. And so we want to make sure that we do that coordinated, that we work together, and that we're good partners. But to say that mobile does this independent and doesn't have a working, ongoing challenge, you know, they challenge each other and work together in this partnership is really important to talk about. There are some tools around some of that work that are listed in the Institute's website, because this is some of the discussions that we've had over the years, and some of the peer-to-peer learning around mobile response specifically. Okay, Hazelyn, you're up talking about some of the racial injustice issues that we're seeing and the impact mobile response and stabilization. And if you want to throw in some of your work around family support, that'd be terrific as well. You're muted though.
Anne made the point, and it's well taken. Those of us who engage with families on a daily basis and are people of color experience our own feelings of internalized racial oppression, and it impacts sometimes, you know, how we are able to adjust and do the work. We always take the approach that it's not about us and it's about the client, or in our case, we don't have clients, we have families. But in truth, this last season has been very challenging for us to somehow step back and say it's not about us. I'm a mother of a son, an adult son. I have 7 brothers. So of course it's personal. I think what I have taken away from this season is the incredible gift of having courageous conversations that we've not been able to have before, and to feel safe in voicing some of our concerns about how we move forward. What does the path forward look like? How can we do this together? It's not by denying the feelings of one group or another. It's not by disregarding the opinions or experiences of others. And in an interesting way, I think it's positioned us, particularly those of us who do this work from a family perspective, to really organize, educate, and advocate for change in ways that we've not been able to do before, because the issues were there, but they were under the surface and no one was really talking about them. But the data was there, the data around disparities in early diagnosis for autism, the data around, you know, access to mental health services, and how old is a child, how many years before they were they seeking help before they actually found it. The data was there, but now we're talking about it in sort of a broader community that I think enriches the conversation and offers a lot of potential for healing and for thinking creatively together about how we create a more just, equitable, and accessible system that serves all. And my final point on this is, it's not lost on me that systemic racism harms everyone. It is not just something that harms people of color. It's a blight
Yes.
That really has been hidden for too long or not discussed, that diminishes our humanity. And so I think this is a fine moment, a divine moment in many ways, to look at how do we, as practitioners, whether you're a clinician, whether you are a clinician and a family member, whether you're just a member of the community, a person with of conscience and goodwill, how do we do this together? And I think looking at educating children and listening to their stories is incredibly powerful. Um, I'm going to stop. I could really go on for a bit about this, but I do want to share one experience that we had here at the Family Support Organization that I think was very moving. Early on, right after the murder of George Floyd, we hosted a call-in session. It was by far the session that had the most attendance of anything that we've done. We brought in a clinician who was a Black woman, who's also a specialist in grief and trauma. And she's the mother of sons as well. And to hear even the young people speak about how this affected them and how much it meant to even just have a safe space to talk about it openly together was incredibly powerful. And I think it cemented my view that, and we always say this here, we're better together than we are apart, but it really cemented my view that we are better together. And the family voice is incredibly powerful in informing policy and informing systems change. And so we continue to educate, organize, and advocate wherever we can and however we can, and join forces with other groups. There are groups of mental health clinicians who are also anti-racist organizers here in New Jersey. And we're having conversations with those groups. We're looking at how do you modify some of the trainings that are offered and making those trainings more known to families so that they too can learn alongside the professionals and share their experiences of what it's like to be the mother or father of a child with autism and feeling fearful that if they interact with law enforcement, it may not turn out so well. So we're looking at how do we do more of that community building together.
I think that your comments are so important on this discussion of how we begin to build a better tomorrow, right? Around the issue of bringing, taking the data and looking at the data and addressing some of the challenges, but really the openness and willingness to communicate and solve problems seems to me like that's one of the most important takeaways from some of the work that's currently getting done. So I appreciate you talking about it. I do want to just touch on a couple things that have come up in the chat, and I don't want them for us to miss them. Number one, Hazelyn, there's a question about the IEP process, and maybe you could talk about that just a little bit more in detail. As sure. I just want to make sure folks get their questions answered.
So IDEA is the federal law under which the individualized educational plans fall. And within that, there is a section called Related Services. The little known fact is that there is an opportunity for parents to request parental training. And that's something that's part of the Related Services, along with speech, physical therapy, speech therapy, I mentioned speech, occupational therapy, and other transportation. So that's an avenue for parents to utilize to request additional support, whether it's due to limited English proficiency or limited use of knowledge of how to use technology. That's an opportunity, and it's certainly supported by IDEA and the IEP.
Great, thank you. And Craig, there seems to be a few questions around the app. If you could talk just a little bit more in detail about the app for folks, that'd be helpful.
Sure, it's the Safe UT app. It is just a chat-based app. It's also what our school districts use, similar to what Ann mentioned in Nevada. Kids can provide tips, so it's also a tip way for schools to be alerted to information. But it's really geared for children and youth. They are rolling out different versions of the app for law enforcement, for our military, different versions of the app. That way people can, without stigma, chat with anybody online and then be connected into the crisis system as they demonstrate urgency. There's also a way that they can break that third wall if there becomes something emergent, like someone is threatening to die by suicide. We can break that third wall and then intervene with the crisis team.
Sounds great. Thank you.
Mm-hmm.
And back to the chat, there's ongoing conversations about the discussion around the use of police, which is really not surprising given the current discussion that's happening in around the use of police in mental health situations. So I just want to again clarify, mobile response and stabilization is an upstream intervention in which we get there early. There is some discussion around the use of mobile response and stabilization in domestic violence situations. And let me clarify, mobile response and stabilization is an upstream intervention. Doesn't mean that it wouldn't respond there. And there does need to be some concern, some discussion about when and how mobile response is used to address situations in which there are real concerns around the adults for the children who we're talking about, right? So I'm not saying police never respond, and I'm not saying that we defund the police. I'm saying, and I want to be very clear, that we train police officers, we partner with police officers, we have to have clarity around the weapons that are in the home, clarity around the situation that children are in. But when mobile response and stabilization is used and the investments are used, we get to see that children are, that the service is used at a much earlier time, and it can calm situations within homes much, much quicker. One of the challenges I think during COVID is that families have been delaying care, not just physical care, but they've been delaying the care for behavioral health as well. And mobile response teams seems to be getting there a little bit later than they would have. At least that's been some of the reporting from some of the mobile response teams that we've been doing some work with. So I just wanted to put that out there. There are some strategies that we can talk about around training police officers and when to go in with police officers. Generally, a good rule of thumb is if there are weapons involved, then the tool belt of the police officers is the right tool belt to use, okay? Okay, so there's another question around staffing models for the rural communities. Since we have two, and I had a feeling this was going to be a question, and this is why we have two folks from pretty rural parts of the country. And you want to talk a little bit about the staffing models in Nevada?
Sure. So the calls all come through Las Vegas's staff, because that is the staff that's there 24/7. So we have routed all of the calls and all of the screenings and intervention calls through that hotline. And if it is a call for a rural youth or a frontier youth, we send that immediately then out to our teams who are responding by telehealth through a video platform in the rural areas. And so they are staffed 7 days a week, but shorter hours. One of the opportunities that COVID has provided for us is the ability for our rural region, who is staffed 24/7, to get on telehealth and to get on video platforms. And that is now going to allow us to provide that after hours coverage and response capabilities to cover rural. So as of COVID, we are now 24/7 statewide, which we had not been before, with the exception of the telephone use. So
congratulations. I know that was a long time coming, and you've been working very hard to get there. Craig, I was wondering if you had some thoughts about, since I know your work right now is really expanding in the rurals, but also you're looking at some frontier work as well.
Yeah, so this has been an interesting year. In addition to having that healthcare, the largest healthcare provider in the Western US, join as our administrator in a very rural part, we received a SAMHSA grant to expand into Eastern region, which is very frontier and rural. And we've been talking to that community through some different sessions to look at non-traditional providers and to demonstrate to them the flexibility to be creative in the geographical challenge of it. And not only that, one of the big pieces for us was in the recruitment and hiring. hiring out there is going to be very challenging, especially for that clinical level. So how do we leverage clinicians? We always want our teams to go out in a 2-person team. So instead of a traditional, like a caseworker and a clinician, maybe we could be creative about it in having, part-time teachers or teacher's aide or nurse's aides or people who have retired from nursing, who have a strong connection in those communities, understand the climate and the cultures of those communities, but still want to be a change agent in their community, and then are guided via a clinician through telehealth. Are there ways that we can pilot some approaches like that? And that's piqued the interest of that region, because initially they're saying, we can't staff this. We cannot keep our own organization staffed. So stay tuned is all I can say for what we'll do in Utah. But it's allowed us to really flex and see, it's the basis of this is about responding to children and families as they see the responses driven, and that we're there when they say we need help, that we're not then putting them on a wait list. So how do we man that? We're going to try to be really creative in using other areas of the workforce while still trying to keep that clinical integrity to this.
Great. So one of the questions in the box talks about training police officers around the cultural diversity within communities. And I just want to touch on this. One of the most powerful things about mobile response and stabilization teams is their ability to know and understand the landscape that they work in. The communities, what they look like, they're there. This is where they live. This is where the communities that they serve. And because of that, they are able to understand what the challenges are, and the training for police officers can be very individualized. In this particular comment, there's a focus on African-American and African-American culture, but that would also be true for a very rural frontier community, making sure that we understood those communities and the languages people speak. I come from New Jersey. It's a very diverse state. We needed to understand what the staff and workforce needed to look like, what tools they needed to have in their tool belt in order for them not only to reach the youth and families themselves, but police officers, understand the situations within the schools and the schools that the young people went to, understand the landscape around, is it a resource-rich environment or resource-poor environment? Do you have a lot of informal supports or community supports? All of those things are really, really important in the mobile response model. So understanding the community inside and out is one of the first things that mobile response teams generally do work on. Did I get that right, Anne? Is that one of the things you've been working on?
Yeah, most definitely in our rurals. So our clinicians who are responding by telehealth may not be specifically in that rural area, but the manager of that team has built relationships in all of the rural and frontier areas. So we are partnering with our rural regional centers and our rural clinics in those areas. We built relationships with the schools and the police departments and the rural hospitals. And in each of our rural or frontier areas, none of them are the same, right? So depending on which region or which community you landed in Nevada, it has its unique culture and identity, and that's really important to that community. And it's critically important that we know what that is and that we honor that, and that we understand when we're responding to a family in Winnemucca that it's going to look different than when we're responding to a family in Tonopah. And we have to understand the resources and that climate and all of that. So our rural teams, I think, have an incredibly challenging task to know all of that and be able to individualize their approach and their intervention and their interactions with the families in these communities. And they do an amazing job with that.
Thank you, Anne. Hazel, I was wondering if you could talk a little bit about the New Jersey model of bringing folks together through the Children's Interagency Coordinating Councils to talk about some of the community challenges.
We have the kayak, affectionately, that's what it's called locally. And that's a body that brings together a lot of the different provider agencies and the system partners, the Care Management Organization, Mobile Response, the Family Support Organizations, the child welfare representatives, Division of Child Protection and Permanency. Some schools are represented, or school districts are represented increasingly, and I'm tremendously encouraged by that because they're an essential player in all of this. And we look at data regarding, what's happening with the children and families in our local communities. And I think there's a unique opportunity there to increase the family voice in that. Some of us have begun to do work in partnership with various entities, such as various other parent groups. So for example, here in Essex, later this month, we will have a family forum where families will talk about some of the very issues that we've been talking about today as it relates to individuals with developmental disabilities. And that information will make its way back to the kayak in the form of a series of, questions and or recommendations around increasing access, earlier, doing a better job with early diagnosis for children of color who on average, have a 3 to 6 year gap from the time they ask for help and the time they actually get a diagnosis. So it's a great forum for that. And I don't know if New Jersey is unique in that way, but it's certainly a vehicle that systemically we're looking at how can we enhance family participation in that and collaboration between all of the partners, including families having a central voice.
Thank you. Thank you. As part of the other discussion in the chat, Christopher, you might be able to help us a little bit on this discussion around the boarding that's going on in emergency departments. You mentioned that that you've been seeing some of the data. I was wondering if you could share what you know about the boarding that's happening and maybe defining boarding for this group.
Sure. So boarding is when a child ends up in the emergency room and there is a determination that they need admission to an inpatient or acute stabilization unit and there's no beds for them. And so they're often either admitted to a pediatric floor where there may be some mild consultation from a child psychiatric team, or they stay in the emergency room. Or in the case of one of our respondents in the chat, are boarded essentially at home, and in this circumstance over 30 days. And we are seeing rates of boarding going up again in Massachusetts significantly, where children who have been determined to need an inpatient admission aren't admitted for over a week or longer. And then in informal discussions of other inpatient child psychiatry directors, they're reporting similar circumstances across the country. I think this reflects the increased need. I also think that a number of inpatient units are making COVID precautions where they may not be doubling up in rooms. Residential units have also tried to decrease their capacity to address the public health aspects of congregate care settings. And that's put pressure and backup in the entire system. So there's increased need and there's decreased access, which I think makes mobile response and stabilization so critically important if you are able to divert those children from even ending up in the emergency room in the first place. But that means your capacity to do either in-person assessments or telehealth assessments in real time to prevent it from escalating to the point where the child is in such crisis that somebody has to call an ambulance or the police or just get them into a stable placement like an emergency room where they can be managed until a determination of what ultimate needs they have are determined.
That's really helpful. Thank you. I have two questions from the box I wanted to address. One is there's a question a little bit more for me to give a little bit more information on the child welfare component for children going in foster care. So let me just give you a little bit of history. I worked in New Jersey for a long time. But one of the data points we were really concerned about as we were focusing on children in child welfare was that it would take 6 moves within foster care in order for the child to touch on the behavioral health system. And then we would really be at a point where the discussion would be, we need a residential and we need it today. And so we really dug down into the data, tried to figure out what was happening. We read the stories, we talked to people who were engaged with young people. And our first question always ended up, why didn't you use mobile response and stabilization, which was available to you? And we learned that there were some training issues and misunderstandings. And so we did a pilot in which we trained all foster parents, they're called resource parents in New Jersey, around how to use mobile response and stabilization. And the local mobile response teams actually came to the table to help. They were great trainers, they partnered, they worked through the details, anything that might get in the way. And we piloted in one county in which the child welfare system said any child over the age of 4 who was removed from their home because of abuse and neglect and going into a foster home would receive a visit from a mobile response team, and that mobile response team would do an assessment. They would assess to see if there were the child was in need of more behavioral health services, and we would make those behavioral health services happen. They would also basically have a calming conversation with the young person around their own trauma, right? This has been something big just happened to you. Because something big just happened to you, you might have a hard time eating, sleeping, paying attention. School might feel different. Happens for some children, doesn't happen at all. But if it happens to you, we know what to do about it, and we'll be here to help you. Same conversation with foster parent, teaching them how to use the behavioral health system for a child who might experience some effects of the trauma of the removal and whatever else had happened in the home. That pilot was very successful, so successful that the child welfare system in New Jersey put it in policy, and it's currently used on a regular basis across the state with ongoing local trainings and conversations between mobile response teams and with the child welfare system. So it's been really helpful. I think you can see it in some of the data in New Jersey in the reduction of over-reliance on residential interventions. You can see the numbers have gone down since 2014 when that work first started. And so I'm happy to talk more about that. If you want more information, please reach out to me. I'm really happy to share more about that. Another question, I was just waiting for that question to come up, and that is, how is mobile response and stabilization funded in different places? And the answer in some places is Medicaid, but why don't we just ask folks at this, ask some of our parents. So Craig, do you want to talk about how SMR is funded?
That's a puzzle. No, so it was initiated during juvenile justice reform. We used that money saved through that reform process to seed our first SMR team in our first region. And then since that time, we did have the largest healthcare provider in the area, the Children's Hospital, donate money to be the SMR administrator. We also have a mental health block grant, and then just recently a system of care SAMHSA expansion and sustainability grant that we'll be expanding with. But the pieces, the really important part of those grants, so it's not just a matter of continuously chasing grants, those grants are to seed and ground that. While they're in action and we're standing up those teams, we're out there working with legislators, we're out there working with the data, who have we deterred from these systems, and then recapturing that money to reinvest in these services and expanding those.
Thank you, Craig. How about you, Ann?
So we are funded in a variety of ways with the state-run programs. So some of the funding is coming from State General Fund. Some is coming from Healthy Tobacco Funds, so the 100% or the tobacco funding, settlement funding. And most recently, we have shifted our mental health block grant this year to focus on some specialized and targeted programming within mobile response and stabilization. So that is a new shift in terms of how we're funding mobile.
Thank you. Hazel, and I'll take New Jersey for you. New Jersey's mobile response and stabilization is embedded in Medicaid. All children who are Medicaid eligible, the teams bill Medicaid. For children who are not Medicaid eligible, New Jersey has figured out what they call a Medicaid lookalike number, and they use a behavioral health carve out from the state to ensure all children get the service. New Jersey took the idea that it's a public service, it's a public health approach to providing good mental health services for children. So all children are served regardless of their ability to pay. Happy to talk more about that at some other point if people want to reach out. Happy to do that. But I also see that some folks in the chat have shared that. So I appreciate you sharing how you're funded and what it looks like, because I think this is a very important service within the service realm. I also just want to point to one other thing for you. In 2013, CMS, the Center for Medicare Services, and SAMHSA put together a joint letter to the Children's Behavioral Health Directors talking about what a service array would look like. Mobile response and stabilization is one of the services in the service array that CMS and SAMHSA both support, although they call it mobile crisis response, and we've moved a little bit down the road on that language. It is a service that is very much supported by both CMS and SAMHSA and should be part of the Medicaid plan that's in place for children who meet the criteria for Medicaid. So I just want to put that on the table as a long-term sustainable plan. And in some states, there is some we're including mobile response and stabilization as part of their Family First Prevention Services Fund. It's not an evidence-based practice, but there's some promising practice and some good data that's coming out. So it might be something to consider if you have the ability to talk with some of your child welfare partners. Okay, so we're getting close to running out of time, and I do want to give the panelists just an opportunity to do some closing comments. So let's just take a minute. Craig, if you had to leave this group with a comment, what would it be? What would you tell them?
I would say for me, it's of all of things we chase, it's just staying focused on the family, listening to the families and letting the families drive the experience. That's what got us into this situation to begin with. And as we've looked and tried to shift, SMR in Utah is very young and growing, and there's a lot of opportunities, but I always come back to that. Are we listening and driving the system to the families? Is the family experience easy? Are there barriers to that family in getting services? And if so, then that's a choice we don't make. It's always about that family experience and letting them determine how we respond and when we respond.
Thank you. Hazelyn, your parting comments.
Sure. I believe the most important thing we can do during this season and moving forward is listen to and incorporate the voices of families, regardless of where they are, what their perspectives might be, and how they may differ from ours. We can learn and grow together, and it's important that we stay on the growing edge.
Thank you. Christopher.
Well, I think people have been so creative in adapting to this unprecedented crisis of a pandemic. And as we said in the beginning, I think there were adaptations to your practice that you're going to want to continue after there's vaccine and successful treatments and we're on the other side of this. So I would really be looking at that, and particularly in terms of the funding question, if we can make the case that those adaptations are better serving children and families, then we can use data, hopefully, to inform the policy side of things and ensure that we're able to continue those adaptations post-pandemic.
Thank you. Anne?
So I would say that one of the most beautiful things about mobile is our ability to serve anybody when they need us, where they need us, and not have a rubric or criteria or exclusionary practices that don't allow them to seek services and support from us when they need it. And so that is really what I want to leave us with, is that mobile allows for us to serve entire communities whenever, for whatever reason, that a youth or family might need to access us. And I just think that now more than ever, we need to have something that does that.
Thank you, Anne. And my parting comments are these. I think mobile response and stabilization is one of the most important services that states and communities can provide for children and families. It is worth the investment, and it is an investment. It's a long-term investment in care. And given all that's going on in the world today, supporting children and nurturing families before things escalate into significant crisis is the most important work that we can do. And if there are things that we can do to be helpful, please reach out. I'm happy to answer questions. And the Institute has done some really interesting and creative work around helping states come up with new ideas around providing that care for children. So I want to thank you all for joining us today. I'm going to hand back to Denise.
Great. Thank you, everybody. And Sarah, if you don't mind bringing up our closing slides, that would be fantastic. While Sarah's doing that, some of you have been asking about certificates of participation. You'll receive instructions with the follow-up email. Follow-up email will include the recording as well as the resources shared in the chat box. Many of you have been very interested in that today. I do want to thank you on behalf of the Institute for Innovation and Implementation at the University of Maryland, Baltimore School of Social Work, for joining us today. As Hazelyn said, we are very much better together than apart. Please consider joining us on Tuesday, December 8th. We'll talk about how to talk about racism and advancing our work to support children, youth, and their families during COVID-19. Also consider joining us in the new year. 2021 has got to be better, right? On January 26th, a conversation on in-home behavioral health, supporting children, youth, and families during COVID-19. To obtain more information about these discussions and other resources Liz referenced, please go to our website. Next slide, please, Sarah. Several of you have asked, how do I get in touch with Liz? How do I get more information? Here's my email contact. We can put Liz's email up in the chat box as well. If you're interested in joining our mailing list, please go to the Institute theinstitute.umaryland.edu/. There's my email address as well. And Liz will put hers in the chat box. And if we can have the next slide too. We do appreciate all of the feedback you've given us in the chat box. As I mentioned in the beginning of this discussion, an evaluation will pop up in a moment. Please do take the time to complete this brief evaluation. We're very interested in hearing from you, particularly about discussion topics you would like featured in this series in the new year. We appreciate all of you very much, as the feedback does help us make this series better and more responsive to our needs. And please, everybody, continue to take care of yourselves while taking care of others. Thank you so much for joining us today, and thank you so much to our wonderful panel. Take care, everyone.